Everyone once again for joining us. So today will be the second part of management of pain. So we have been hearing a lot of questions on opioids since the last few sessions. So today we'll be dealing with the step 3 drugs with focus on mostly on opioids, on morphine. Today we have Dr. Sunil Kumar as the faculty. He is the additional director of Trivandrum Institute of Palliative Sciences. Dr. Sunil is working with palliative care and Pallium India for nearly 20 years, and he has done his post-graduation in palliative medicine from Cardiff University. And he's heading the clinical as well as the academic department in Pallium India. And yeah, he has done this session, wonderful session for many, many batches. And please make it interactive because we know that we all had questions on opioids, stepping up, when to follow up, how to titrate, when to step down. Every questions we have been you have been asking during the last few sessions. So today we'll be discussing mostly about that. So please feel free to ask your questions during the session. Make it interactive. Thank you so much, Dr. Sunil. Over to you.
Thank you, Sridevi and Priya, and good afternoon, everybody. So let me start sharing the screen. Is it visible now?
Yes, sir.
Okay, so as Sridevi told, we will be dealing with the strong opioids or opioids for moderate to severe pain. And the mechanism of action of opioids. And there will be many questions regarding the practical issues that we can come across while we use opioids, which we will try to answer. And there are many adverse effects which can occur with opioids. So we will look into what are the adverse effects of opioids and how to manage that. And another important thing would be the pharmacoeconomics of opioids, because many representatives will be coming to you and asking you to prescribe some patches or some other drugs, and we should understand what is the pharmacoeconomics involved in that. So this is the brief outline regarding the session, and we'll move on to the session as such. So all of you know this is the WHO analgesic ladder, in which we have opioids from the second step onwards. In the second step, we have opioids for mild to moderate pain, or some people call it as weak opioids. And all of you know that in that step, we have tramadol, tapentadol, codeine, and dextropropoxyphene. And in the third step, we have opioids for moderate to severe pain, or strong opioids. And can anybody tell me what are the strong opioids available in India? You can unmute and speak.
Fentanyl and morphine, sir.
Yeah, thank you.
Morphine, sir.
Yeah, anything else?
Buprenorphine, sir.
Buprenorphine, yeah, in a way it is a strong opioid, but it has its own problem, and so it is not widely used. So we don't consider it as a step 3 medication or step 3 opioid. Anything else? Morphine and fentanyl. In addition to that,
Methadone?
Methadone.
yeah,
Pethidine, sir.
methadone. Yeah, that's correct.
Pethidine.
So this methadone. Yeah, so these are the 3 strong opioids available in India. Okay. So can anybody tell me what is the problem this man is suffering with?
Anyone would like to unmute? And just
Drowsiness. Okay. Anybody else?
Maybe CA mouth or something like that.
What does his face tell you?
He's very distressed.
Yeah.
He's emaciated, sir.
Yeah, he is emaciated. That's okay. But you can see his facial expression, isn't it? He is suffering from severe pain. So this is a patient came to us with a very severe pain around the neck. Okay, who is suffering from carcinoma of the larynx, and he says his pain is 10 by 10. That is the worst imaginable pain, and it was there for more than 2 months. But for the last 2 weeks, it has been aggravated, and there is no radiation, and he is unable to sleep because of that pain. So if you see a patient like this, he comes to your clinic, how will you manage this patient? Anybody?
Any responses?
Go directly to step 3.
Yeah, go directly to step 3. Thank you, Dr. Srikanth. Which medication would you like to use?
Some morphine.
Okay. Yeah, morphine. So what formulation of the morphine are you going to use?
So we first start with 5 mg morphine IR trial.
Okay.
To assess the response after 30 minutes of post-therapy trial.
Mm,
With PCM, of course, 650.
mhm. Okay. So suppose how long will it take to get good pain relief with morphine tablet?
So oral morphine, 30 to 40 minutes. It should get elicit a response from the patient. Oral morphine.
Okay. So, maybe at least half of patients may not have response with 5 milligram of morphine. So we have to give another dose of morphine, and we have to wait
Yes,
for
sir.
another 40 minutes, isn't it? Suppose one of our close friend or one of our relative is suffering from severe pain. How fast would you like to have pain relief for that patient?
So we start with IV PCM and followed by morphine.
IV paracetamol followed by tablet morphine?
Tablet morphine.
So
Okay.
we'll directly
Prefer
start with
IV,
IV.
prefer IV morphine directly.
Yeah.
Every
4 hours.
Even in the chat, there are responses on IV morphine and then calculated tablet.
Yeah. So if you have one oral morphine tablet only, then you have to give an oral morphine trial. Otherwise, you can have an injection morphine trial or injection morphine titration. Okay. So injection morphine titration after about 40 minutes, the patient is smiling. Okay. So how do you do an intravenous morphine trial or titration? So there are various methods for doing intravenous morphine titration, but the method which I'm going to mention here is a method developed by our chairman and his team. So this is giving injection morphine 1.5 milligram every 10 minutes interval. Okay, so the morphine ampule which is available in Kerala is 15 milligram in 1 ml. So we will dilute the 1 ml of morphine with 9 ml of normal saline. So total it will contain 10 ml. 10 ml contains 15 milligram of morphine. Each ml will be 1.5 milligram. Yeah. So do you expect any immediate side effect by administering injection morphine?
Patient will have constipation, sir.
Okay, patient will have constipation.
Drowsiness is the more
Sorry, Dr. Ravi.
drowsiness.
Drowsiness. Okay. What other immediate side effect are you expecting?
Respiratory depression.
Respiratory depression.
Nausea.
Vomiting, nausea, vomiting.
Yeah. So it is nausea and vomiting that is going to be seen after immediately after administering injection morphine. Okay, so you have to first give an antiemetic. So we gave injection metoclopramide 10 milligram IV, followed by injection morphine 1.5 milligram at 10 minutes interval. So how long would you continue to give injection morphine like this? How many doses would you give? Anybody?
Till the patient feels drowsy is one response in chat.
Okay.
Till patient has pain relief.
Okay. Okay. So endpoint is either the patient should have satisfactory pain relief or the patient should develop drowsiness. And you have to add whichever be the first. So all the pain will not be morphine sensitive. So what will happen if you give injection morphine trial? Sometimes the pain may come down to an extent, but then patient becomes drowsy. Patient may not have satisfactory pain relief, but patient becomes drowsy. That means you have to stop the trial then. But some patients will have good pain relief and there will not be they will not be having any drowsiness. So you have to stop the trial. So whichever be the first, you have to stop. Okay. So for injection morphine trial, for morphine titration, you can make a chart like this, which includes time, pulse rate, blood pressure, respiratory rate, pain score. Is the patient drowsy or not? What is the dose of injection morphine you have given? So in this patient, we are going to start a morphine trial at 10 a.m. and you will record all the vitals, including the pain score. At first, it is 10 by 10. Patient is not drowsy. So you will give injection morphine 1.5 milligram. Then you will wait for 10 minutes. So at 10:10, you will again assess the patient for pulse rate, respiratory rate, blood pressure, and you will ask the patient pain score. Now it is 7 and patient is not drowsy. You will again give 1.5 milligram. And you can see in this patient at by 10:30, the patient pain score came down to 1. That means patient has satisfactory pain relief and patient is not drowsy. So this is an indication to stop the injection morphine trial because the patient has satisfactory pain relief. So you will stop the injection morphine trial. So in this patient, we have given total of 4.5 milligram. Okay. So you have given 4.5 milligram of IV morphine. So is this an inpatient procedure or outpatient procedure? Anybody? How should we do it? It's an inpatient or outpatient?
Inpatient, sir.
Inpatient? Anybody else?
Outpatient.
Outpatient. Okay. So injection morphine titration in this fashion, you need not admit the patient. This can be done on an outpatient basis. Okay. So we do injection morphine trial maybe 1 or 2 in every day. So it is an outpatient procedure. So you want to discharge the patient after the pain relief. So you have given 4.5 milligram and you want to discharge the patient with the oral morphine tablet. So what would be the dose that you are going to start on with this patient?
10 milligram.
10 milligram. Can you tell me how did you reach 10 milligram, Dr. Sami? Or anybody else?
Sir, IV to oral morphine is multiplied by 3, is it?
Yeah, so
So it becomes 13.5 mg.
yeah. Okay. Any other opinion? Thank you, Dr. Aganksha. Sorry if I spelled it wrong. Okay. We know that when we convert morphine from IV to oral, we should multiply it by 3. But this is applicable only when the blood level of morphine is stabilized with intravenous infusion. So for stabilizing the blood level with intravenous morphine, it will take about 24 hours. But for this patient, we have given only 1 or 2 or 3 doses. It has not given over 24 hours. So blood level is not stabilized. So the conversion factor of 3 will not be applicable here. So I told you that we are practicing a method which has been published in Journal of Pain and Symptom Management, which practices converting the same dose of IV morphine to oral dose. So 4.5 milligram of IV morphine, when you convert to oral morphine, it will be 4.5 milligram of oral morphine, because the blood level is not stabilized with IV morphine. Okay. I hope it is clear.
Are there any questions
Sir.
regarding the conversion?
Yes, no, sir.
Yes.
It's a 4.5 milligram per day you are talking, no? Not depends upon the
No,
day.
this is 4.5 milligram of IV morphine, single dose, isn't it?
Okay.
Of course, he received at 10 minutes interval. But what would be the duration of action of this morphine?
4 hours, no?
Yeah, 4 hours. So that means you have to give morphine every
Every
4
4
hours. Yeah. So 4.5 milligram of oral morphine is not practical, because we have only 10 milligram tablets, or sometimes there will be 5 milligram capsules. So what will you do? You can round it to the nearest possible dose. So you will give morphine like this. Tab morphine 10 milligram, half when the patient wakes up. Then at 10 a.m. and 2 p.m., 6 p.m. and at bedtime, we will give double dose. In addition to this, you can also give an SOS dose. SOS dose would be the same as regular dose. Here the regular dose is 5 milligram. Okay. So in order to remember it, you can make it 6 a.m., 10 a.m., 2 p.m., 6 p.m. and 10 p.m. But we know that patients in pain will be sleeping most probably during the morning time. So we need not wake them up to give the medication. So you administer the first dose when the patient wakes up. Maybe it is by 7 or 8 a.m. And then you administer the next dose at 10 a.m. itself. Like this, you need not wait till 10 p.m. You can administer it at night when the patient wants to go to bed. So maybe by 8 p.m. or 9 p.m. But if somebody wants to take it 10 p.m., it's okay. So usually administer doses, the double dose of the regular dose. So you can see the regular dose is 5 milligram, but at bedtime you give 10 milligram. Okay. So in addition, you are also going to give 5 milligram as SOS dose. So many of you may not have injection morphine. So in such instances, you have to give an oral morphine trial in which if the patient has not taken any opioids, you can start with 5 milligram. And if the patient is on any weak opioids like codeine or tramadol, you can start with 10 milligram. Okay. So we will follow up this patient. So this patient, we started him on 5 milligram morphine 4 hourly and with SOS dose. And he had good pain relief for the last 2 weeks. But then he started needing 4 SOS dose of morphine. So in addition to the regular dose, he is also take 4 SOS dose per day, last 4 days. So do we need to do anything with the morphine dosage? You can unmute and
We can increase the dose
okay, we can increase the dose
to the next level.
How much would you increase?
5 become 10.
Okay. Thank you. And if anybody else has any opinion, you can tell me.
Sir, extended release tablet we can do.
Which one?
Extended sustained release tablet, sir. After
Sustained release
calculating.
tablet. Okay, so in this patient, how much do you like to start?
So this patient is taking 5 mg 430. So in a day he's taking 30 mg.
Hmm.
And other than that, he's taking SOS 5 mg 4 doses. So total he's taking 50 mg in a day. So we can titrate it like 10 mg 4,000 and then probably give 60 mg in a day and then see how the pain response is.
Okay.
There is a response in the chat, increase the dose and make it to 10.
Okay. Okay, we can discuss that. The second point was how frequently would you give SOS dose of oral morphine? Suppose the patient has taken morphine by at 6 a.m. and the patient is complaining of pain at 6:30 a.m. Patient tells that my pain is still there. It's very severe. What will you do?
Increase the dose.
Increase the dose?
Like 5
What else?
milligram sustained release tablets, there is one response in the chat. In breakthrough pain, we can give SOS, Dr. Anubha is telling.
Okay. So would you give the SOS dose at 30 minutes? Okay. So as you told, we can increase the dose of morphine. So what is the indication to increase the dose of morphine? When the patient is taking 2 or more than SOS dose. PRN is same as SOS dose. Okay. So if the patient is taking 2 or more than SOS dose, you can increase the dose by 30 to 50%. Actually, every 24 hours you can increase. Okay. So in this patient, if you calculate the dose, what is 30% of 5 milligram? It will be 1.5 milligram. So total dose would be 6.5 milligram, which is not practical to give. So the nearest possible dose would be 50% of 5 milligram, that is 7.5. So you can increase the dose to 7.5 milligram. And sometimes some patients find it very difficult to make the tablet into 4 pieces. So even 10 milligram 4 hourly is okay in this patient. So we can increase from 5 to 7.5 to 10 milligram every 4 hourly. So the indication to increase the doses when the patient is taking 2 or more than SOS doses. And every 24 hours, you can increase the dose. How frequently would you give SOS dose of oral morphine? Okay, for this, we need to understand a little bit of pharmacology. So, you know, this is the poppy plant, and its scientific name is Papaver somniferum. The poppy plant is legally cultivated only in 3 states in India, UP, MP, and Rajasthan. And you can see the seed-like thing, which is known as pod, pod. And the farmers make small cuts on the pod so that the sap will ooze out. The farmers will collect this sap and dry it in sunlight, and then they will transport it into government opium and alkaloid factories, where they will make morphine powder out of it. And this morphine powder will be used to make morphine tablets or capsules. Okay. So morphine is water soluble. It is hydrophilic. So because of this, morphine has a slower onset of action, but has a longer duration of action. And it is absorbed from the upper small intestine. These are a few points which I think is important. Morphine should not be given sublingually, buccally, or gingivially, because it will not be absorbed properly. And if you powder the morphine tablet, it have a bitter taste. So you have to sweeten it with some juice or sugar. So morphine should not be administered sublingually. And sometimes some people I have seen that they are telling that the morphine have administered sublingually and the patient has good pain relief. So what you have to understand is that if after administering sublingually, if the patient has pain relief, that means patient has swallowed it. So what happens when you take morphine tablet? It will be absorbed into the blood vessels in the upper small intestine. And from the blood vessels of upper small intestine, it will go into the portal vein. And from portal vein to liver, where the metabolism takes place. And these metabolites are liberated into the systemic circulation. And only 10 to 20% of parent morphine will be bypassed liver, will bypass the liver and will directly reach the systemic circulation. So the main factor which gives pain relief is by metabolite. So what are the main metabolites of morphine? It is M3G, M3G, which is known as morphine 3 glucuronide, and M6G, morphine 6 glucuronide. And in the M6G is the active component which will give you the pain relief. And M3G doesn't have much action in our body. But note that the component which will give you pain relief is formed in less quantity, only in 5 to 10%. Okay. So morphine has to go into the GI tract, from where it is absorbed and goes into the portal vein and then to liver, where metabolism takes place, and then liberated into systemic circulation, which will give you the pain relief. So for this process to occur, maybe the analgesic action may start occur by 30 minutes, but it peaks by 1 hour. So it is better to wait till 1 hour before the next dose. So if the patient is patient has taken a morphine tablet at 6 a.m. and tell you that at 6:30 a.m. My pain is still there, I think maybe it is better to wait for another 30 minutes. So 1 hour would be the optimal time difference, because that's where the peak analgesic action occurs after oral administration. So our patient, Mr. X, pain was stabilized with 10 milligram every 4 hourly. But the patient says it is very difficult for me to take it every 4 hourly. This is a very common problem which we see with many patients, isn't it? And the patient tell you that if you give it less frequently, I am willing to take it. What can you do?
Sustained release.
Yeah, sustained release. So in this patient, how will you start sustained release morphine?
There is a response, sustained release morphine 30 mg BD with 10 mg IRSOS.
Yeah. So in this patient, you can see he is taking 10 milligram every 4 hours, isn't it? So the duration of action of sustained release is 12 hours. So 10 milligram every 4 hourly means that is 60 milligram. So you can divide the dose into 2 and make it 30 milligram SR tablet BD. So 30 milligram SR tablet is available, 10, 20, 30 and 60 is available. So you need to administer only twice, and with 10 milligram immediate release morphine as SOS dose. But the problem is that SR is costly, maybe 4 to 5 times costlier than the IR morphine. And these are the preparations of morphine available for us. Aqueous solutions, tablets, 2 types, immediate release and controlled release. and injection morphine. So the patient was then titrated up to 10 milligram every 4 hourly for the and he's having good pain relief for the past 6 months. But then when you were on duty, this patient was brought to you complaining of excessive drowsiness. On examination, it was found that he has a serum creatinine of 5 milligrams per deciliter. So do you need to do anything with the morphine dosage? And why this patient has excessive drowsiness?
We'll decrease the dose of morphine as his renal function is not good, sir.
Why this patient is drowsy?
Because of the morphine 6 glucuronide. So there's delayed excretion and it stays in the circulation for a long time, and this is the reason for the drowsiness.
Yeah.
And the pain might have been reduced is one response. And Dr. Matangi is telling prolonged action of morphine.
Yeah, this patient was taking morphine for the last 6 months. That means his pain was stabilized with the 10 milligram every 4 hourly, but suddenly he became drowsy. So probably it is not because of pain relief. It might be due to something else. So when you look at the lab investigation, the creatinine is 5 milligrams per deciliter. What is the significance of increased serum creatinine here? So morphine is excreted by the kidney. So what happens in renal failure is that the M6G, morphine 6 glucuronide, and morphine and its metabolites accumulate in renal failure, and that causes drowsiness and some other symptoms. So what you have to do in this patient is maybe you have to skip 1 or 2 doses of morphine till the patient becomes alert, and then you have to start the patient on a lower dose, and the spacing can also be increased. So instead of 10 milligram 4 hourly, you may start with 5 milligram 6 hourly or 8 hourly, something like that. Or you can use renally safe opioids. So what are the renally safe opioids?
Fentanyl, methadone.
Yeah. Fentanyl and methadone. Yeah, that's correct. So that's also another option. So Mr. X was sent home. Okay. And we have reduced the dose of morphine to 5 milligram 8 hourly. After 2 months, he was unable to swallow anything, including morphine. But the patient is having good pain relief on 5 milligram 8 hourly. But now he is unable to take anything. So what will you do for pain relief now? You are seeing this patient during a home care.
Fentanyl patch.
Sorry?
Fentanyl patches.
Fentanyl patch. Okay. Anything else?
Crush the morphine is one response.
Syrup morphine.
IM morphine, crush the morphine.
Syrup morphine.
Or parenteral morphine.
Okay. IM morphine, you need to give injection, isn't it? The patient is at home. Will you give injectable morphine to patient at home? Will your hospital allow it? I'm not sure. Yeah.
Buprenorphine patch.
Buprenorphine patch. Okay. So how long will buprenorphine patch will take to have pain relief?
8 hours.
8 hours?
48 hours.
48 hours.
Yeah, it depends on the strength of the patch, and maybe at least 10 to 12 hours. So here we have to understand what are the routes through which you can administer morphine. We know that most common route is oral, followed by intravenous or subcutaneous route. And usually intramuscular route is not advisable for patients with chronic pain, because we know that we are giving injection morphine for pain relief, but one of the main side effect of any intramuscular injection would be the pain, isn't it? So IM route is not usually advisable, and we don't use the IM route at all. And another route is parectal administration of morphine. Then, as you know, epidural and intrathecal can also be used. So in this patient, which route will you advise? The patient is at home.
Parectal, no?
Parectal. What would be the dose that you are going to use?
5 milligram.
Same dose.
Yeah, it's same dose, same frequency. Okay. So oral route is comparable to parectal route in case of morphine. And some people say it is even superior to oral route. So you can use the immediate release morphine for parectal administration. You can take the tablet, add 2 drops of water. I told you that it is water soluble. Make it a paste and then rub it over the rectal mucosa. So the patient will have good pain relief. Okay. So this is the practical solution when the patient is at home.
So one doubt, why did you
Yeah.
say about making it in a paste form? Why should we make it in paste form?
Because the absorption would be easier.
Okay, so
Otherwise,
instead of putting it like in a direct tablet, you can make it
yeah,
into
make
paste.
it a paste.
Paste and apply. You should apply, I think, inside.
And the rectal mucosa.
Okay, so
Do a rectal examination and just rub on the rectal mucosa.
but sir, the patient has to continuously do it, no? Himself.
Yeah, in this patient, it is 5 milligram 8 hourly. So
He
you
has
have to give it to 8 hourly.
Okay.
But if this is more, if this is going to cause more problem or discomfort for the patient, what we do is you can take the butterfly needle and cut the needle with hub and insert that small tube into the rectum. And administer the dissolved morphine with a syringe. That can also be done.
Oh, good. Thank you.
And I see that even the sustained release morphine can also be used. That's what I read very recently. But we use a fast-acting tablet. Morphine suppository was available in the West previously, but I think now it is not available. In India, it is not available.
So we can manage with a normal tablet.
Yes.
Okay.
You can manage with normal.
Thank you.
So this is another patient, Mrs. K, 55-year-old lady with carcinoma of the colon, has abdominal pain. It is continuous in nature and has good pain relief with 10 milligram morphine 4 hourly. So she doesn't require any SOS dose of morphine. And so the doctor advised them to replace the morphine with a fentanyl patch of 25 microgram per hour. But the patient reports to you next day telling that they have replaced the fentanyl patch after 5 hours as she had no pain relief. What are you going to do now?
So before applying the patch, we need to tell the patient that the patch works after 10 to 12 hours. So we need to take the morphine dose as such she's taking, and after 10 to 12 hours, she need to assess the pain and then take the morphine 10 mg SOS as and when required.
Yeah, thank you, Dr. Ravi Kiran. So these are some practical problem which commonly occurs. Actually, this is a patient who came to us and told us this story. So what we have to understand is fentanyl works by creating a subcutaneous tissue depot. So when you apply the fentanyl patch, it will first create a subcutaneous tissue storage. And for this storage to occur, it will take about 8 to 12 hours. And from this storage, fentanyl will be constantly liberated into the systemic circulation. That's how it acts. So it will take 8 to 12 hours. So if you don't tell the patient that, okay, till this time, it will not work. And till 8 to 12 hours, you have to continue with morphine. Then the patient will be expecting pain relief like that of morphine. But here, the patient need to wait for 8 to 12 hours. So till that time, you have to continue with the morphine. Okay. So, and as you know, the duration of action is for 72 hours, 3 days. Fever and the skin condition, like if there is any aberrations, that is going to increase the absorption of fentanyl. This is another important thing. It is not, or it should not be used for patients with unstable pain. So if the patient has a very acute pain, you should not use fentanyl patch. Or if the patient has a pain that is not controlled, then also you should not use fentanyl patch. Only those patients who have a stable pain. That means you have controlled the pain with some short-acting opioids. And now you know that this patient needs this much dose of morphine, and then you can convert it into fentanyl patch. So these are the preparations available. Injections are available, which is used by some centers only. Then transdermal patches, oral transmucosal fentanyl citrate. So this is OTFC is like a lollipop, which you can rub it on the buccal mucosa. So this was very useful when the patient has incident pain, which will act very instantaneously. It is unlike morphine, this is lipophilic, whereas morphine is hydrophilic. And compared to morphine, it is 100 to 150 times more potent. What do you mean by potency in case of yeah, here? What does potency means here? Anybody?
Dose required for achieving the same effect.
Yeah, yeah. That is the weight by weight ratio to achieve the same effect, to achieve the pain relief, same pain relief. So for practical purpose, you can take it as 100 times more potent. That means 100 milligram of morphine is equal to 1 milligram of fentanyl. And if you calculate like that way, the 60 milligram of oral morphine per day would be equal to 25 microgram patch. So I am moving on to another patient. This is Mr. P, 70-year-old man, has carcinoma of the lung and is complaining of throbbing pain on right front of chest, which is continuous and scores 5/10. That is moderate pain. He's a non-epileptic and is on phenytoin 100 milligram BD. How will you manage his pain? Anybody?
Sir, seems like a neuropathic kind of a pain. Because
Morphine
it's a
5
carcinoma.
milligrams.
Can give reduced dose.
Sorry?
So there's a chat.
Can be given reduced
morphine
dose of
5
morphine.
Sorry, please speak one at a time.
Sir, there is a chat on 5 milligram morphine trial. 5 milligram 4-hourly plus 5 milligram SOS. I'm sorry, I interrupted someone. I don't know who spoke at that time. Madam, can you just repeat what you were telling?
phenytoin is enzyme induction. So I think dose required may be more. Dose.
Okay. Okay. But which opioid are you going to start here? This patient has a moderate pain, isn't it? So which step of
Tramadol.
analgesic ladder?
Step 2.
Yeah, step 2. So which medication are you going to use?
Like tablet tramadol plus we can give some anti like paracetamol.
Okay, thank you, Dr. Ruji.
There is a chat from Dr. Ravi telling we avoid tramadol and tapentadol in this case.
Okay, Dr. Ravi, why would you like to avoid?
Sir, it may increase the threshold of seizure activity, the tapentadol and the tramadol, as a effect of increasing the seizure threshold activity, as is already on epileptic agents.
Yeah, thank you. So, one of the thing that you have to understand about tramadol is that it will reduce the seizure threshold. That means there is a chance of precipitating a seizure. This patient is already a non-epileptic. So, when you give tramadol for this patient, it may precipitate a seizure. But I haven't seen any patients having seizure with tramadol till now, but it is described in literature. So tramadol would not be an option here. So what else could be given?
Codeine.
Codeine. Okay.
Codeine and paracetamol combination.
Yeah. What else?
Sir, must be a neuropathic pain because it's a carcinoma, so we have to rule out whether there is a leg.
Sorry, it's very
Chat,
hard.
we are unable to understand what you're telling. The voice is very low and unclear.
I will type it in the chat.
We can use tapentadol.
Tapentadol also has the same problem like tramadol. Okay.
Considering this age, why don't we consider 5mg Q6 Tarley, PCM paracetamol 650 TID, and the other adjuvants?
5 mg morphine?
Q6 hourly.
Okay. So that's the option here. So you can use morphine in a lower dose, maybe less than 30 milligram. So if you use morphine less than 30 milligram, it is considered as step 2 medication. Okay. I won't use codeine or tramadol in this patient. I will use low dose morphine. Codeine is actually costly. And nowadays, most of the centers are not using codeine. So we will move on to another patient. Mrs. P on tab morphine 50 milligram 4 hourly. She attends your clinic with severe pain. You have injection pentazocine and oral morphine tablet. How will you manage the pain of this patient? Anybody?
This patient looks stable right now.
Yeah. Patient.
This our Raja.
Okay.
Anyone would like to respond to this question? Like either injection pentazocine.
You have two choices: injection pentazocine or oral morphine tablet.
There is one response: injection pentazocine can be given till the threshold.
Okay. Anybody else? Okay, let's go on to a little bit of pharmacology again. So opioids, what are opioids? So a drug to become opioids, it should have two properties. One is that it should produce its effect by combining with opioid receptors. And the other one is its action should be antagonized by naloxone. So these are the two properties for a drug to become opioid. And the opioids act on opioid receptors, and the receptors are mu, kappa, and delta, which is seen throughout the nervous system. Previously, it was thought it is there only in the central nervous system. It is not like that. It is there in central nervous system as well as in peripheral nervous system, but it's most abundant in central nervous system. And according to the action on receptor, the opioids can be divided into three: agonist, antagonist, and agonist-antagonist. Agonist means when an opioid combines with a receptor, it will produce the physiological action. That means it will produce pain relief. Okay, that is an agonist opioid. What is an antagonist? Anybody? Antagonist means it is
against the
it is the antidote for opioid, isn't it? So antagonist will work only in presence of an agonist. So if I give you the antagonist naloxone to any of you, it will not have any action in your body because you are not taking any opioid. It will work only in presence of an opioid. And agonist antagonist means on some receptors it will act as agonist, whereas on other receptors it will act as antagonist. So it will have both action. So this is the main difference between agonist and agonist-antagonist. So you can see here in case of agonist, on the x-axis it is the dose of agonist, and on the y-axis it is the pain relief. So suppose this patient had a pain score this much, 10 by 10. Okay, and you give maybe a little bit of agonist, morphine, 5 milligram, and this is the dose, and you will get this much pain relief. When you increase the dose, you will get corresponding pain relief. And when you increase the dose up to the red line, it will give 100% pain relief. So agonist, in case of agonist, with increase in the dose, it will also produce corresponding pain relief, and theoretically, it will give 100% pain relief. That means there is no ceiling effect for analgesia, no ceiling. Okay. But in case of agonist and agonist, you can see as you increase the dose, it will give corresponding pain relief up to a point, up to this red line. And you can see after this red line, even if you increase the dose of agonist and agonist, the curve plateaus. Okay, it will not give more pain relief. That means it has a ceiling effect for analgesia. So this is the main difference between these two groups of medication. Agonist and antagonist have ceiling effect for analgesia. Agonist doesn't have ceiling effect. So what is pentazocine? Pentazocine is a agonist at kappa receptor and a weak antagonistic action at mu receptor. But morphine is a mu agonist. Pentazocine is antagonistic at mu. So what happens if you give pentazocine to a patient who is already on morphine? What will happen?
It will antagonize the action of morphine.
Yeah, the pentazocine will replace morphine from the mu receptor, and now the mu receptor will be occupied by pentazocine, and the pain relief will be due to kappa receptor only. And you have to understand that the opioids acting on mu receptors are the potent analgesics. So kappa receptor can give pain relief, but Now we have given pentazocine, and pentazocine is at the mu receptor, which produces antagonistic action. So theoretically, this patient is on high dose of morphine, 50 milligram 4 hourly, that is 300 milligram. So it can actually cause more pain in this patient. Okay. So in this patient, actually we need to take history whether this patient has missed their dose, because we know that when they travel, they may not take the medication properly. And if the patient has missed, you have to give the missed dose of morphine, or else you can increase the dose of morphine. And it is better to avoid injection pentazocine. So now I will move on to the adverse effects of opioids. Adverse effects can be divided into two. One is side effect and the other is toxic effect. So what are side effects? These are the adverse effects with therapeutic doses. So what are the side effects? Can anybody tell me what are the side effects?
Constipation.
Nausea, vomiting, constipation, pruritus.
Yeah.
Drowsiness.
Okay. Most common things should come first. It is constipation. Then nausea, vomiting, sleepiness and tiredness.
Respiratory depression.
Respiratory depression will not come here. We will talk about it later. So constipation, nausea, vomiting, sleepiness and tiredness. These are the most common side effects. And there are some rare side effects: itching, dry mouth and urinary hesitancy. These are rare side effects. And constipation, what you have to understand is almost all patients will have constipation. And it will be there as long as the patient is taking opioid. So you should give regular stimulant laxative. So I am underlining the word stimulant laxative. Okay, that is the drug of choice for opioid-induced constipation. The examples of stimulant laxatives are bisoprolol, senna, and sodium bicarbosulfate. There are many mechanisms by which opioids produces constipation. That's why we have to use a stimulant laxative for treating opioid-induced constipation. And nausea and vomiting occurs in almost 1/3 of the patients. But if the constipation lasts long, the nausea and vomiting occurs only for the first few days, maybe 3 to 5 days. So it is mainly due to stimulation of chemoreceptor trigger zone. There are other mechanisms also involved. So you have to give an antiemetic for the first 3 to 5 days. So what antiemetic should be given for treating opioid-induced nausea and vomiting?
Metoclopramide.
Okay. In the chemoreceptor trigger zone, the most abundant receptors are dopaminergic type 2 receptors, that is D2 and 5-HT3. So what are the strongest D2 blockers? The strongest D2 blocker is haloperidol, followed by metoclopramide and domperidone. And some centers use haloperidol, but some centers use metoclopramide. It has its own advantages and disadvantages. We use metoclopramide. And sleepiness and tiredness, it is also self-limiting. It occurs only for the first few days. You need not do anything. And we divided adverse effects into two: side effects and toxic effect. So what are the toxic effects? These are the adverse effects when the administered dose is higher than the required for pain relief, or when the patient's pain has poor opioid sensitivity. And it can manifest by many ways. And some of the important pointers are delirium, myoclonic jerks, drowsiness, undue drowsiness. Okay. And pinpoint people. So if the patient has delirium, myoclonus, and undue drowsiness, think about toxic effect. So as I told you earlier, you have to skip a few doses and start with a lower dose. And this is one of the concerns raised by some of you. opioids producing respiratory depression. How common it is if you give it for pain relief?
Usually it happens with overdosage only.
Okay. So this is a systematic review from 2003, and it says usually patients takes their medications orally. That is, morphine is usually given orally, and we usually increase the dose gradually, isn't it? So that ensures that respiratory depression is unusual. And it continues to say that when respiratory compromise does occur, you should seek an alternative explanation, such as pneumonia, pulmonary embolism, or cardiomyopathy, or co-administration of another sedating medication, such as benzodiazepine. I should say that during the last 18 years of my career in palliative care, I haven't seen any patients with respiratory depression due to oral morphine. So it is not common at all. It is very, very rare if you properly titrate the dose of morphine. And what about this?
Sir, I have a doubt.
Yeah.
Now, what about with IV morphine also?
Yeah, even with the IV morphine, if you give it in a titrated fashion, as we told earlier, 1.5 milligram every 10 minutes, it is not going to cause respiratory depression.
Okay.
And you are monitoring the patient also. So it is not usual to have respiratory depression with any dose of or any formulation of morphine.
Okay.
If you properly monitor the patient. Anybody about addiction?
Comment in the chat about dose required for analgesia is lower than that required to cause addiction.
Suppose if a patient is on atenolol for the last 5 years and you are stopping atenolol suddenly, what will happen to the patient?
Rebound hypertension will happen.
Yeah, what else? Tachycardia?
Yeah, all the effects that was caused by metoprolol now.
Yeah, thank you, Dr. Bikram. So why is it, why these manifestations?
Because these receptors that were blocked by metoprolol is now open for others hormones and all those things to act upon. So there will be tachycardia and hypertension.
Okay, is it addiction?
It will not come in the definition of addiction.
Okay. So let me ask you another question. Many of you might be taking coffee in the morning. So one day you are not getting coffee. What will happen to you?
Drowsiness.
Drowsiness?
Withdrawal effect.
What is the most common?
You become irritable. You become irritable.
Irritable. And maybe headache, irritation, and not feeling well.
Yeah, all those things will happen.
Is it addiction?
Yeah, this is addiction.
Okay. So I want to make a distinction between psychological dependence, that is addiction. Okay, psychological dependence and is addiction, and another time is the which is physical dependence, which is manifested as withdrawal reactions. Okay, so you have the symptoms. I will call it as physical dependence. Okay, which is manifested as withdrawal symptoms. But if you break into neighbor's house where sugar and coffee powder has kept, that means you have addiction. That's the difference between two in simple terms. Okay, so these two terms, physical dependence and psychological dependence, is something that we have to keep in our mind. And the American Academy of Pain Medicine has described or defined addiction like this. It is a disease, okay, in patients who are genetically predisposed, and it's the manifestation of addiction is influenced by psychosocial factors and environmental factors. That means if you have a gene for addiction and if your environment is favorable, suppose you are working in a operation theater and you have a friend who is misusing opioid, that means environment is favorable, you have a gene, then probably you have a chance to get addicted. And there are many manifestations by which we can differentiate addiction from physical dependence. The patient will crave for drugs, and the patient know that the use of this medication is not going to do any good for the patient. It will cause only harm. And they will come to you and tell you that my prescription is lost, my morphine is lost, it was stolen by somebody. These are the types of history that you are going to get. And there will be frequent escalation of dosages without permission of the treating doctor. So these are the some manifestation by which you can differentiate addiction from physical dependence. And so I am moving on to a prescription. Mr. X has severe pain and you are starting him on morphine. Please write a prescription. His serum creatinine is normal. Can anybody tell me what all should be there in the prescription when you prescribe morphine?
Pain scores and a prescription.
Morphine along with antiemetic.
Okay.
Then on bisacodyl.
Okay.
Plenty of water.
Okay.
And rest are the normal treatment.
Okay. What else? What else are required in the prescription?
Pain score should be there in should be recorded before morphine prescription.
So before prescribing morphine, we are going to ask about pain score. That's for sure. But it need not be there in the prescription.
Paracetamol.
Okay. Okay. So
there
this
is a chat with morphine, with paracetamol, perinom, and laxative.
Okay. So these are the minimum things that there should be if you prescribe morphine. The name, age, and address of the patient. Then you have to write the strength of morphine tablet and how are you going to give it, how many days, and how many numbers are you dispensing. And in addition, as you told, you should be writing the stimulant, laxative, and antiemetic. And you have to also write when should you are going to review the patient, and your signature, name, medical council registration number, and address. So these are the requirement as per NDPS Act, that is Narcotic Drugs and Psychotropic Substances Act. Okay. So this is another patient, Mrs. X, on tab tramadol 50 milligram Q8 hourly for pain. Now she has severe pain and has started on morphine 5 milligram 4 hourly. Now the prescription is tab tramadol 50 milligram 8 hourly, tab morphine half Q4H and half SOS, syrup liquid paraffin 15 ml/HS. What are the corrections required here?
We will not give a weak opioid and a strong opioid similarly at the same time concurrently.
Yeah, thank you, Dr. Satyajit. Anything else?
So again, there is stop tramadol in the comment.
Yeah.
So regarding the last slide, Dr. Praveen has asked about what is. Dr. Praveen, you wanted to know what is rescue dose? Like there is a query, rescue dose question mark.
Yeah.
Just type exactly what you want to do.
Yeah. The rescue dose would be.
Is there a need to designate what could be the rescue dose when it could be taken in the prescription? That was my question.
Yeah. You can see this prescription. It is written as half SOS. because half is given as regular dose. So it should be half SOS.
Thank you, sir.
Thank you. So what else need to be changed here?
I mean, along with the morphine, you should add antiemetics. That's missing.
Okay.
The night dose of the night dose is not mentioned. It's only the Q 4 is mentioned and half SOS. The night dose should also be mentioned.
Okay, but if somebody write like this, half Q4H means it is understood that at night it is given double dose. It should be okay, Dr. Satyajit.
Okay, the duration.
Stimulant laxative?
Yeah, that's one thing missing here. Patient is getting liquid paraffin. So the drug of choice is stimulant laxative. So we should add bisacodyl. Okay. So it should be like this. And this patient is already taking 50 milligram of tramadol 8 hourly. So that means he is taking already weak opioid and he doesn't have proper pain relief. So you can step up to directly start on 10 milligram for hourly, or otherwise you can calculate the dose of tramadol and then convert it into morphine also. Tramadol is 1/10 as potent as morphine. So you can add bisacodyl, you can continue, or later you can add liquid paraffin.
Dr. Sunil, I just had a doubt.
Yeah.
Do you need to give a concurrent drug like a stool softener along with a stimulant laxative, or just a stimulant laxative is good enough with patients on morphine?
Yeah, this is a big question, but I would advise to start with the bisacodyl at first, and if needed, you can add liquid paraffin or any other laxatives. And this is something which you need to understand, because many of the patients will come to us and we may prescribe many things, but the patient may not take. And one of the important thing for improper symptom control or unsatisfactory symptom control is they are not buying it because of they don't have money to buy it. So this is very important. So I have calculated approximate doses of all the opioids required for same pain relief.
So Dr. Ravi is asking about tapentadol to morphine conversion.
It is tapentadol is 1/3 as potent as morphine. So here morphine 5 milligram Q4H, which will cost 3 rupees 50 paise per day, whereas tramadol for the same pain relief will cost about 24 to 50 rupees per day, and fentanyl patch maybe 75 rupees to 100 rupees per day, and methadone only 4 rupees 50 paise per day. So this is the comparison, and buprenorphine will cost more than this. There are many people who are promoting the patches, but the patients may not be able to afford it. So we need to be careful while we prescribe opioids. So with this, I think I will stop here. And if there are any questions.
There is a question already in the chat about how many morphine tablets can be prescribed at one time.
Okay, I think as per NDPS Act, it doesn't specify about the duration for which you can prescribe. But from a you have the person who is prescribing also have the duty to make sure that it is not used for some other way. So maybe it is better to prescribe at the most for 1 month. And we usually prescribe for 2 weeks. And if the patient is from far away places, we give it for 1 month.
Dr. Ravi, you have a question?
Good evening, sir. It's a very wonderful presentation. I have two doubts. what is the conversion factor for the morphine in order to be prescribed to buprenorphine patch? And how do we convert morphine to methadone and methadone to morphine?
Okay, so Dr. Satyajit, sorry,
That was Dr. Ravi.
Dr. Ravi. Practically, we don't use buprenorphine at all, but from the literature, I understand that 12 milligram of morphine, oral morphine, is equal to 5 milligram of buprenorphine patch, and 24 milligram of morphine equal to 10 milligram of buprenorphine patch. And buprenorphine patch, it's the duration of action is 7 days, and the potency is 100 times more potent compared to morphine. But in case of sublingual buprenorphine, it is 80 times more potent.
Yeah, hi, Dr. Sunil. Thank you for the nice presentation. I have one question. What are the maximum daily dose of morphine that can be prescribed to a patient?
Okay, thank you, Dr. Bigas. I will answer that, but before that, I think I need to answer one more question from Dr. Ravi: how to convert methadone to morphine and morphine to methadone? It doesn't have a linear relationship. That means you can say a tramadol is 1/10 as potent as morphine at any dose, but it is not like that for methadone. Suppose the patient is taking less than 60 milligram of oral morphine, then the dose of methadone required would be 2.5 to 2 to 7.5 milligram per day. And if the dose is between 60 to 199 milligram of morphine, the conversion ratio is 10:1. And above 200, the conversion ratio is 20:1. So there is no maximum dose of morphine. The dose required for the patient is the maximum dose for that patient. I have used 5 milligram or even 1 milligram BD for patients to 450 milligram for hourly for a patient. And I know that my colleague has used 650 milligram for hourly for a patient. And from the literature, it says there are patients who are on thousands of milligrams of morphine. So there is no maximum dose of morphine.
Dr. Satyajit, you have a question?
Yeah, Dr. Sunil, once again, thanks for an excellent presentation. I just had a doubt, like when we are sort of escalating the dose of oral morphine in case of inadequate pain relief, say you go from 5 to 7.5 milligrams 6 hourly. So what happens to the SOS doses? Do you increase it by the similar amount, or is it the same SOS, or how do you titrate the SOS doses then?
Yeah, when you increase the dose of opioid, then you give the dose as per the increased dose. So 7.5 milligram means 7.5 milligram of SOS dose. There are many ways of calculating SOS dose, but from a simple point of view, you should use the same dose which you are using regularly.
So maximum, how many days you can continue this morphine? After 1 month, if the patient is coming, so you have to continue with the medication for how long?
Okay, so that depends on the pain of the patient. Suppose you have a patient with the malignancy, and the patient has severe pain, and you have started him on some dose of morphine, and the patient is not on any curative treatment. That means the pathology which produces pain would be there, and probably you have to continue with morphine. And once you feel that, okay, this patient has very stabilized pain, there is no other problem, and then you may try to reduce the dose of morphine and see whether, I don't think it will be possible, because you are not doing anything to cure the underlying pathology. So probably you have to continue with the same dose.
So there is a question in the chat. If the patient cannot come, can it be given to the caregiver for longer periods, like a month?
Yeah, we do give it to the patient, but before giving it to the caregiver, just talk to the patient if possible over the phone, and find out what the condition is.
Dr. Ruchi, just a moment. I would like to ask Dr. Nidhi, She's supposed to do the case presentation today, but I think this discussions are going like very good discussion. So is it your questions are being answered, Dr. Nidhi? Is it okay to proceed without the presentation of the questions?
Yeah, sure.
So sorry. Like these are the questions that may need more discussion. Thank you so much, Dr. Nidhi.
Sure.
Yes, Dr. Ruchi.
Ma'am, I want to ask what lab parameters should we follow in a patient if the patient is on long-term morphine treatment? Any lab parameters we need to follow, and when should we ask them to get it done?
Okay, so usually the patients on morphine doesn't require any lab investigation. But if you feel that, if you see that this patient is developing some toxic symptoms, like he was on stable dose and he didn't had any problem, but suddenly he is developing myoclonus, delirium, drowsiness. Probably it might be due to poor renal function. Yeah, so at that time you can order for a renal function test. Otherwise, we don't do anything, any lab investigation.
Okay, thank you, sir.
There is a sir, Dr. Sharvanan is asking about opioid rotation.
Okay, so opioid rotation, it is indicated when there is pain relief, when there is unsatisfactory pain relief with one opioid, or if the patient develop opioid-induced hyperalgesia, or some rarely opioid tolerance, then you can switch over from one opioid to another opioid. So, but in case of for us, we have only three options, isn't it? Morphine, fentanyl, and methadone. So if the patient doesn't have proper pain relief, you can try to switch over to methadone. I think all of you should learn how to switch over to methadone. Methadone is not like other opioids. It has to be used carefully. It has its own advantages and disadvantages. But even you can switch over to fentanyl.
Sir, can morphine be stopped abruptly?
Okay. So this is another important question. If you have given morphine continuously for more than 1 month, then you have to taper the dose and then only stop morphine. Otherwise, it will produce withdrawal reaction, which many of us will confuse with addiction. So this is very important. If you have given opioid for any patient for more than one month, please taper the dose and then only stop.
So tapering should be done, sir, according to 4th hourly dose, or should tapering can be done 8th hourly or 12th hourly, like that?
You can reduce the dose by 30%, maybe every 5 days. Reduce the dose by 30% and then come to the smallest dose and then stop.
So, sir, that dose reduction that has to be done 4th hourly only, or we can reduce it to 8th hourly scheduling?
You can do both way. You can do both way. Suppose the patient is on 10 milligram 4 hourly, then he is taking 60 milligram. So you have to reduce by 20 milligrams in it. So you have to give 40 milligram. So maybe you can give 5 milligram 4 hourly, and then move on to 5 milligram 6 hourly, 5 milligram BD, 5 milligram OD, and then stop.
And sir, TDS and
yeah, it can be given.
QID, that is acceptable, sir. Like
it is acceptable.
Pharmacologically correct.
It should be okay, but the problem would be sometime the dose when you give TID, the single dose which you are giving can cause more drowsiness. That's the only problem.
Dr. Mirazu, you had a question.
Sir, for breakthrough pain, should we prescribe same doses of the regular dose we have used for morphine?
Yes. We should use the regular dose. Suppose the patient is getting 5 milligram 4 hourly, that means you have to give 5 milligram as breakthrough dose.
Okay, thank you.
Sir, Dr. Nidhi's question, what is the drug of choice for severe post-operative pain? like spine surgery or post amputation?
I think it can be any opioid. If the patient is on epidural, that would be better. But you have to take out the epidural, and at that time you have to start with morphine or fentanyl injection.
Sir, can opioids be used for non-malignant pain, sir?
That's a very important question. We know that even though we told that patients, if used properly, it may not cause addiction. That may be true in case of patients with malignancies, but in case of patients with non-cancer pain, there is always a chance for more addiction potential. So in case of non-cancer pain, the recommendation is that first you should optimize all the non-pharmacological therapies and other pharmacological therapies, and then only you start with opioids. But if you start with opioid, and never go beyond 60 milligram per day, and frequent follow-ups are required, and at each follow-up you should assess what are the risks and what are the benefits of the patient, and if the benefit if the risk overweighs the benefit, then stop it. And even you have to assess for addiction potential. There are many scales used for to assess the risk of opioid addiction.
So there are two questions on morphine solution about the availability as well as the dosage.
Okay, so I think many places doesn't have a morphine solution, but in Trivandrum, we have a regional cancer center where morphine solution is available. But otherwise, all the other palliative care centers in Kerala gets only tablet or capsules. So you have to ask the dealer in your place whether morphine solution is available or not.
Dr. Praveen, you had a question on intestinal obstruction, but I think I'll take it up during the session on bowel obstruction, because we are anyway dealing in detail. We have one whole session on bowel obstruction.
Thank you.
Dr. Shilpa is asking, can we replace the 4th hourly dose of oral morphine to 6th hourly dose? Dr. Shilpa, would you like to say why you want to replace from 4th hourly to 6th hourly?
Ma'am, can you hear me?
Yes, yes. Yes.
Ma'am, actually, I have seen some prescriptions for 6 hourly. That's why I just wanted to confirm it, whether like you can replace it, because maybe sometimes patient might feel like in our hospital, we have just immediate release morphine, not the sustained release one. So, and patients are on morphine for months. So they might feel like taking it as quite like a 4 hourly dose is difficult. So I just wanted to confirm it.
Actually, that is not a good practice. You have to give it 4 hourly, or you have to give sustained release morphine. Suppose the patient is taking 60 milligram per day. That means 10 milligram every 4 hourly. So if you are going to give it every 6 hourly, that means 15 milligram 6 hourly. So 15 milligram may sometimes cause more drowsiness, and patient may not be active. The whole idea of giving morphine to patient is not only pain relief, the patient should have good quality of life. That's what we are looking at. So I told you that we had a patient who is taking 450 milligram of morphine 4 hourly. And this patient was actually an excise commissioner who later became an advocate, and he had a carcinoma of the colon, and that's why he was started with 5 milligram, I think. Then we had to increase it to 450 milligram for hourly. But he was actively practicing in the court after taking 450 milligram. So that should be our idea.
Okay, thank you, sir.
Sir, 2 questions on the pediatric dose of morphine.
Okay. So
Sir, you are muted.
Okay, so morphine can be used for pediatric patients, and I think the dose is 0.02 to 0.4 milligram per kilogram body weight.
Yes, sir.
Every 4 hourly.
Yes, sir. 200 to 400 microgram per kilogram body weight. I think only challenge will be to crush and make it into that particular dosage, but it can be used for children, even in neonates. Dr. Nishant is asking about the administration of morphine through Ryle's tube. Can it be administered as a solution?
If it need to be administered, you can make it a solution and administer. It's not a problem.
Sir, can we take up 1 or 2 questions more?
Yeah.
Yeah, Dr. Satyajit.
Yeah, thank you, ma'am. Dr. Sunil, I just had a question regarding this non-cancer pain again. We get a lot of referrals from hematology for children admitted with sickle cell crisis and in severe pain. So how do you suggest that we manage such patients? Is it a good idea to start them with oral morphine, or how should we?
Yes, definitely. In such situation, we need to start with injection morphine or tablet morphine. And the other group of people who require opioids, strong opioids, would be the patients with peripheral vascular disease. When there is no option of amputation or anything, they will suffer like anything. So those are another group of patients who needs strong opioids. Sickle cell crisis definitely is an indication.
Sir, maybe last question. Role of morphine in neuropathic pain management, like refractory to standard neuropathic pain medication.
Okay. So in case of neuropathic pain, you know that we are using neuropathic pain agents like tricyclic antidepressants or anti-epileptic medications to treat neuropathic pain. But suppose how long will it take for this neuropathic pain agents to act? Any idea?
Days to weeks, days to weeks.
Yeah, maybe 2 to 4 weeks. So suppose a patient is coming to you with moderate or severe neuropathic pain. What are you going to do for this patient? Are you going to start only on neuropathic pain and allow this patient to be in pain for this 2 to 4 weeks?
No, sir. We would.
So
also
we have to start together with the opioid. And you have to understand that opioids are partially sensitive to neuropathic pain. So sometimes even opioids would be giving 100% pain relief, because I have seen a patient who was diabetic, and he has undergone coronary artery bypass graft, and he had a lot of comorbidities, and he had severe burning pain on bilateral legs because of diabetic neuropathy. And this patient was tried on multiple medication, all the neuropathic pain agents in optimum dose. There is no proper, there is no pain relief at all, and they are unable to use any other medication. So they sent this patient to us, and the only thing that didn't try was morphine. We gave a morphine trial, and he had 100% pain relief. But this may not occur in all the patients. But the important thing is that opioids are partially sensitive to neuropathic pain. So you can use, try to use opioids for neuropathic pain along with other neuropathic pain agents. Once this 2 to 4 weeks is over, you can try to taper the opioid and stop it. And at the same time, you can optimize the dose of neuropathic pain agents. That's what we can do.
Thank you, sir. I think the questions are over in the chat. I'm so sorry, Dr. Nidhi, we couldn't take up the discussion based on your case, but if you have more questions from your presentation, if you have any questions, please, you can, we can give you 2 extra minutes to discuss that. Sorry, we can't hear you.
No questions.
Okay, Dr. Devi, thank you. Thank you so much, everyone, for the very interactive session. Thank you so much, Dr. Sunil, as always, making it so interactive and case-based discussion and making it very lively throughout the session. Thank you so much. And if you have more questions, please send us through the WhatsApp and we'll get back to you with the answers. Sripriya?
Thank you, Dr. Sunil Kumar, for your valuable time and also for patiently answering all our participant queries. I believe everyone would have got at least one point as a new learning from this session. And thank you everyone for making this session very much interactive as we had promised to Dr. Sunil Kumar. Thank you so much. And we do hope that this interaction continues till the end. And another one more note to add that we'll be releasing the first assignment for this cohort soon, shortly, most probably by today or tomorrow. So be prepared for that as well. And with that note, this is Sripriya along with Dr. Sunil Kumar and Dr. Sridevi Warrior signing off from the Tips Eco Hub. See you in the next session with another interesting topic and another eminent faculty. Till then, everyone, stay safe, be happy. Bye-bye.
Thank you.